Top Med Talk. Welcome back to Top Med Talk. I'm Andy Cumpstey and I'm here again at the Evidence Based Perioperative Medicine, the EBPOM World Congress 2025, here at the British Library in London. And we've just finished a really busy day two with a fantastic plenary session. And I'm so pleased that our speaker has agreed at the 11th hour to stay behind for a few more minutes and talk to us in Top Med Talk about the fantastic talk she's just given.
Hi, my name is Anoushka Afonso, and I am over at Memorial Sloan Kettering. I've been there for over a decade. I head up the Enhanced Recovery After Surgery programs there, and I have the pleasure of working with wonderful teams there that have really played a big part into the development of an innovation that is there at the surgical center. Josie Robertson Surgical Center.
So the Josie Robertson Surgical Center specifically for what you called ambulatory surgical care, is that right?
Yes. So we have two types of cases. About 65% are the same day cases. That means you come in and out the same day. Then we have an ambulatory extended recovery, AXR. And those cases are those that spend a night. So the most they can stay there is 23 hours.
Wow. So even...
So one night stay facility for those AXR type patients.
And you talked about some of these patients are coming out of the operating room at 9, 10, 11 p.m. at night.
Some of them do, if they're usually the third or fourth case in a room. It's a high volume center.
And that doesn't change the care they get in any way from what you're saying?
No, they have standardized protocols and all the staff there are very familiar with that. So it really makes for ease of both expectations from the patient and expectations from the perioperative staff that's working with them.
Can you give some examples of what that care might involve or would involve in those pathways?
So we have our ERAS pathways that we published in 2021. Patient education, that's usually done in the surgery room, surgeon's office. We have very robust regional block service. So for our mastectomies with reconstruction, they're offered regional blocks. We have a big emphasis on non-opioid analgesia. We have a big emphasis on post-op nausea, vomiting, prophylaxis with standardized pathways. We have a PONV task force that basically is continually evolved to incorporate the latest guidelines and consensus. For example, ours was just updated to include the fourth consensus PONV guidelines. Every step of the way, we have intraoperative guidelines to allow for all the patients coming in, all the staff coming in, the anesthesiologists, the CRNAs to do the same thing for the same type of patient.
And it's not just the care pathways which are specifically tailored and built for this service. The whole building is essentially purpose-built for this type of care. Is that right?
Yeah, it's hardwired. So there's some technology that was brought in while they were building the facility. And some of the technology is hardwired in the construction of it. For example, the RTLS, real-time locating system. And it's a badge that you put on. Everyone coming in has that badge, the patients, the caregivers. And that allows for really a couple different advantages. Number one, it allows for great communication with caregivers. It allows for the caregivers that are in the waiting room to see where their loved one is. If they're still in the OR, if they're in the recovery room, are they ready for guests now? Number two, once the patients leave the OR, the cleaning crew is alerted to come in. So it allows for better patient flow. It also allows for ability to see bottlenecks. So in terms of workflow, especially in a busy surgical center like Josie Robertson in New York.
You call it a busy surgical center. Can you give us an idea of some sort of numbers to that?
12 ORs. We have 4 ORs on each floor. I showed some data with almost close to 70,000 patients, but that includes both outpatient and ambulatory extended recovery. We have pretty low readmission through urgent care, readmission rate, transfer rate.
You're showing figures of, or single-digit figures.
Single digit, under 3%.
Yeah.
Most of them are from the hematomas. Those are the large percentage of readmissions or takebacks to surgery. For the most part, we've also had a really robust simulation that's really caught up in the last few years, and that trains both the surgical services at Maine and at the ambulatory center, and that's really helped ease, in terms of care coordination. Blue dye reaction, as I mentioned, is rare. However, we have a whole protocol for that. We have protocols for everything.
Well, that was one of the questions I was going to ask. You talk about standardized care, protocol-driven care, simulation care, and then really nicely when you finished the lecture, you talked about looking to the future and personalizing care and AI and individualizing care. How do you see those two things going hand in hand?
Actually, an example of that was one of the studies by Dr. Mu. They used normogram to predict which patients have moderate to severe pain. And they used a few variables that are known. And also they found out that those patients that had moderate to severe pain are the ones with high BMI, the type of surgery more bilateral than unilateral. Those type of patients were offered blocks, regional blocks for mastectomy without reconstruction, which otherwise wouldn't have happened. So again, tailoring of enhanced recovery protocols, tailoring of clinical care to allow for that. And that is led by our wonderful regional attendings. And we have a very robust block program, Josie Robertson.
And you put up some really beautiful photos of the environment inside this building, both from the patient point of view, but also from, I guess, the staff point of view, but also the guests or relatives' point of view, as you put it. Can you maybe talk through some of those features?
Yeah, I think it's really important to building aesthetics, creating clean, modern space to allow for recovery, not to increase anxiety. I think you have that here, Maggie centers. Is that what you have here?
Yeah, we'd have it in the UK as well, yeah.
Yeah, so if you notice some of these Maggie centers, they're designed with the patient in mind.
Yeah.
Not very sterile. They have a home. Patients feel cared for. Anything from the color, the type of art in the building, the music that's playing, the areas for privacy.
And do you think you can demonstrate that makes a change into your outcomes?
I think it'd be really hard because it would be really hard to compare it to a very sterile looking concrete building.
Yeah, you won't have to do an RCT, but I imagine it must make the staff enjoy working there more. Well, it must make patients choose to come to this centre rather than others. I mean, do you get any sense of that sort of feeling?
Most of our breast surgical population come there.
Yeah. So just giving a fantastic lecture to an absolutely full lecture hall at the end of a busy day, and everyone's feeling around the room afterwards was like, wow, why aren't we doing this? How do we all do this? This is not common practice here in the UK. It's not common practice in other countries around the world.
That's why I showed that first slide to say this is what the length of stay is across the world. Ranging from 11 to 12 days in Japan to our center less than 24 hours for the same procedure.
Yeah, which is funny.
Culturally, there's a difference.
Yeah.
Some of the other cultures don't really want to go home right away, or they may not have the support services or caregiver support at home. What I really think is interesting about the place is we have a big caregiver support team. So not big, but it's high quality.
Yeah.
And they interact with the patients. They look and see what type of caregiver support is needed for the patients to best recover at home after their stay.
So do you think for those of us that aren't yet working in these sort of centres or delivering this sort of 23-hour care, that's the thing we should start working on first? Or are there other things we should prioritise changing about our care pathways before that?
I think how the inception of this place first started with doing trial at the Maine of incorporating some of the pathway elements. Education, for example, they started off with minimally invasive prostatectomies. So education, Foley, discharge, nurse-initiated discharge planning. So starting out with a few of those elements that are important or barriers to early discharge, working on those at the main hospital, and then looking at your data and seeing what is feasible and what isn't. And we potentially move these type of procedures to a less than 24-hour stay facility. So I think that would be number one. Number two, all the other things around what makes the building special be secondary, but you have to have the basics of education, expectation, great surgeons, and great preoperative staff to help facilitate that.
And put this into context with the session you did earlier today, which again, also fascinatingly interesting, but in a different way, where you looked at more outcome-based and you talked about RIOT.
Yeah, so RIOT, return in the context of cancer, RIOT, RIOT, return to intended oncological therapy. So cancer therapy, and for different types of cancer, You have neoadjuvant therapy and adjuvant therapy. Neoadjuvant therapy happens before the surgery, and that can be anything from chemo, radiation, etc., depending on what your tumor is. Adjuvant therapy happens after surgery. And so while the timing is different, their benefits may be different as well. For example, prior to surgery, neoadjuvant therapy can potentially make inoperable tumor operable. It could also test out the chemo regimen that they are giving to see if it's even effective prior to surgery. After surgery, after the tumor is out, adjuvant therapy can kill any remaining cells that are not visible. There's a state of inflammatory processes that happen after surgery. And so that state of inflammation and inflammatory cascade can also lead to circulating tumor cells, increased growth of cancer cells. So that is an important point of going back to therapy to mitigate some of this, prevent some of this cancer recurrence. This is very common in a few different types of surgeries. That's why it's really important to get them functionally recovered after surgery, making sure that they don't have complications. What's really important is if they do have complications, there's plenty of data out there that show those patients with complications don't return to the intended oncological therapy early. So if they don't RIOT in the appropriate time, for each week that's delayed, they have an increase in mortality, increase in recurrence. And this is very much seen in the breast cancer population.
And you talk really nicely about some of the things that we can do as perioperative physicians to impact on that. And even what might be seen as the simple outcomes have big impacts, such as postoperative nausea and vomiting, for example.
Yes. So in regards to RIOT, I think using AI and using risk prediction models can really help with figuring out which patients need additional support and which don't, because not everyone has to have the Ferrari car to get from point A to point B. You can have any type of car to get to point A to point B. You just need to get there. And so you just need to get to your cancer treatment after surgery. That's what patients want to cure their cancer. And surgery, as I showed before, is not necessarily the final stop in their cancer journey.
Yeah. And I think we sometimes maybe forget that as perioperative physicians, that the journey really isn't the full picture for these patients. And again, two contrasting slides you finished with, our neat view of pre-op, intra-op, post-op is a very different view from the patient's view with that horrible, twisty, spirally diagram with up and down and snakes and ladders and going both ways.
Because that's real life. And we don't realize that. We like to fit patients and their journey into these buckets and very neat diagrams as they transition home. But in reality, that's not the case.
Yeah, well, I think that's a really strong and powerful message to finish on. So thank you very much for staying behind at the end of a very long day.
Thank you.
Thank you for joining us, Top Med Talk. Again, thank you for listening at home. As always, you can listen to Top Med Talk on our website, on podcasters, through social media. If you do any of those things, please do give us a thumbs up, hit like. It really makes a big difference to us. And thank you again to our sponsors that keep us free and open to us around the world. It's BD and GE. Thank you.
Thank you.
Top Med Talk. Next week on Top Med Talk, perioperative pain medicine and promoting diversity in healthcare. A deep dive with David Story, Professor and Foundation Chair of Anesthesia at the University of Melbourne, Head of the University Department of Critical Care, and the President of the Australian and New Zealand College of Anaesthetists. Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that. ebpom.org is the website address.